How many times have you been to yoga, Pilates, or the gym, and your movement looks like this? You ever wonder why your core is always bulging, or that the movement never feels right? If you're feeling frustrated that every time you go to train your core, either the movement feels really shaky or your low back is doing a lot more than it should, this video is for you. And how does this device, this real-time ultrasound scanner, have anything to do with treating and assessing your abdominal wall? Those are the questions I want you to have answered by the end of the video.
Work your core!
I work out my core. Do not work out your core.
Core training is something we're all familiar with. In short, your core is responsible for transferring forces, bending, spinning, rotating, and doing all kinds of incredible movement. It's something that's been studied extensively in the research, with the belief that strengthening your core muscles will help with the #1 most common complaint out there: low back pain. Core strengthening is without a doubt a multi-million-dollar industry. And with all the information and misinformation out there, it's no wonder people get confused.
Look, ordinary crunches only work on the way up and can strain. But CoreMax's power-assisted spring assists you in both directions, just like a personal trainer, targeting your upper, middle, lower abs and obliques, on the way down and on the way up.
Truth be told, I'm in the belief that there aren't necessarily any bad exercises. What's most important is how they are done. As a physiotherapist, I try to assess and teach the proper timing pattern of core muscle recruitment, which can be difficult to see if you don't know what to look for. And herein lies this concept of motor control. Motor control refers to the motor, sensory, and central processes involved in the control of posture and movement. Optimal motor control for movements of the trunk and the back are thought to be accomplished by having the muscles at the core and the low back fire in a timely, sequential pattern. First, let's go over a quick anatomy lesson of the abdominal wall. At the most superficial muscular layer, we have the rectus abdominis, which flexes and compresses the trunk and provides support to the adjacent abdominal structures. Next, we have the external oblique and internal oblique, the second and third abdominal wall layers, which both work to flex, laterally rotate, and compress the trunk. Finally, at the deepest layer, we have the transversus abdominis, which is a muscle that's been researched extensively for its purported role in motor control. It's the muscle that is responsible for drawing the abdominals inwards, and the ability to recruit these muscle fibers well is thought to be the key component for core stability. Naturally, most people who want to find out more about this idea of core stability will turn to the internet. A quick Google search shows conflicting results. On Wikipedia, it will say, "There is little support and research for the core stability model, and many of the benefits attributed to this method of exercise have not been demonstrated." And then if we turn to Physiopedia, an encyclopedia resource for physiotherapists to turn to, it reads, "Currently, there is strong evidence for specific motor control and specific muscle activation in isolation, progression to more global and functional exercises." Alright, so how about the opinion of those who work in clinical practice? What do they say about the importance of core stability and low back pain?
So to sum it up, first of all, the TRA does probably not have a corset function to stabilize the spine. Second of all, we are not able to accurately assess the TRA or multifidi function in practice.
Now, I love the physio tutors, but I would argue that it is possible to assess the TRA in clinical practice. Shout out physio tutors if you ever watch this video. Now, it seems they came to this conclusion based off a study that assesses the transversus abdominis using a pressure biofeedback unit, which in my opinion is a device that needs to be burned in the trash can for its poor intra and inter-rater reliability. It's essentially this idea that if you lay on an inflated cuff and perform that abdominal draw-in maneuver, that pressure cuff will be able to tell you the strength or the lack of strength of the muscle. And surprisingly, it's still taught in Canadian physiotherapy schools. What they are not looking at, however, are studies that assess the abdominal wall using real-time ultrasound. And this is an important screening tool to assess what transversus is doing in isolation, but more importantly, how it's integrating with the other muscles of the abdominal wall during loading tasks. More on that later.
Third, slow strength training for the TRA or multifidi does not transfer to onset timing of contraction. And last, neither onset timing nor strength or endurance of the TRA and multifidi are relevant for positive outcomes.
Neither timing, strength, or endurance of the TRA or multifidi are relevant for positive outcomes. And this is something that's been shown in the literature. But why don't we actually take a deep dive into what the literature looks like? In this systematic review article published in 2014, researchers analyzed 29 articles through a meta-analysis
which is a type of study that collects all relevant data and averages out the findings into a single conclusion. They concluded that when looking at studies comparing motor control exercises to alternative, general exercises in people with low back pain, there was no statistical or clinical difference in outcomes. Meaning, when we sum up all the data on average, there was no evidence that motor control training was more superior than general exercise in minimizing low back pain. On average, both worked in comparison to no treatment.
However, this leads me to a lot of questions.
Number 1. In these studies, the inclusion criteria is fairly nonspecific. People in the trials were adults with nonspecific low back pain of any length of time. Their pain pattern had to include, but were not restricted to, pain and stiffness between the lower rib and buttock crease that presented in conjunction with or without leg pain. The studies don't indicate if the low back pain is relieved or aggravated by certain movements, which is a useful screening strategy to identify what treatment approach will be effective.
Number 2. In these studies, we're not entirely clear what their motor control strategies are because individual assessments have not been conducted.
There appears to be no evidence to show that a physical assessment was conducted to determine if the person was appropriate for motor control training. In other words, if they already had an optimal strategy. Without an assessment, we don't know if their low back pain is being driven from somewhere else, such as stiffness in the hamstrings, thorax, or anywhere else in the body, and these are the people who may have more favorable outcomes in the general exercise trials, as it may address these regions indirectly.
Number 3. If we don't understand what their baseline is for motor control, how are we going to know if the training that we give them is actually appropriate or not?
Furthermore, if we look specifically at what some of these studies found, we have varying results. The study by Wang in 2012 split 60 adults with greater than 3 months of low back pain into 2 groups, one with core stability exercises and the other with monitored general exercises. Interesting enough, there was a significant difference in favor of Group 1, the core stability group.
But when we look at some of the other studies,
Moon in 2013 found that when splitting 21 adults with greater than 3 months of low back pain, there was no significant difference between the group that received stabilization exercises and the group that received dynamic strengthening exercises.
So why are people in the general exercise group improving? Some hypotheses could be that time spent doing the general, relatively non-specific exercises are good for the following reasons.
Number 1. Exercise prevents us from spending time in sustained postures. Doing something is almost always better than being stationary. Number 2. General exercise increases blood flow and provides nutrients to tissues by increasing the heart rate, which can also be enough of a catalyst to improve mood and psychosocial health. As we know, low back pain is multifactorial, and not always solely due to biomechanical impairments. Number 3. Some people's low back pain may not be caused by motor control deficiency in the first place. There are all kinds of people who would benefit from release techniques at the compensatory areas, perhaps the lower thorax or the pelvic floor, and that's what's driving the low back pain. These people may not benefit from motor control training.
So what can we take away from this systematic review? In my experience, the effectiveness of exercises can be highly dependent on what the individual presents with. And this is one area where the real-time ultrasound can be an effective way to determine one's motor control. Let's see how that looks in clinical practice.
The ultrasound probe is placed on the lateral abdominal wall to get an image of the muscles. At the top layer, we have the subcutaneous and superficial soft tissue. At the second layer, the external oblique, third layer, internal oblique, and at the bottom, we have the transversus abdominis. On an abdominal draw-in maneuver, we should see an independent shortening of the transversus abdominis as it slides along the fascia of the internal oblique. Note, on the patient, we should not see any abdominal protrusion or transverse plane rotation at the pelvis or thorax, or any posterior or anterior tilt at the pelvis. The assessment of the abdominal wall can be split into 3 regions: upper, middle, and lower fibers. We would assess the upper fibers if the infrasternal angle appears narrow and the ribcage sits low, or there are subjective feelings for low rib discomfort. We would assess the middle fibers if there is localized low back pain in the mid-lumbar region. And finally, we would assess the lower fibers of transversus if there is lower lumbar spine pain, pelvic girdle pain, or a history of pelvic floor symptoms. The key takeaway is that transversus should not be assessed as one muscle. The recruitment strategy in the regions of the muscle can differ independently from one another. Some people may have excellent control of their lower TA fibers, but poor control of their upper TA fibers. To load this muscle and make the task more challenging, the patient will move their legs through a range of motion. As you see, the assessment progresses to become more challenging in order to identify where the failed load transfer occurs. Here, the patient loses control of the transversus abdominis during a head and neck curl-up task in the tabletop position. there is a loss of fascial integrity and transversus slides over the internal oblique muscle. Here is where you may see abdominal protrusion, shaking, rotation at the pelvis or thorax, or any other indications of failed load transfer. Once we have identified the patient's capacity, we would then have him or her work towards training the level of transversus with a lower load task, working up towards that same task after weeks of training.
A criticism on the relevance of transversus is that how can it possibly be a stabilizer of the trunk if it doesn't generate rotation? Well, the job of transversus isn't necessarily to generate rotation. It pretenses the fascia, then the big muscles, the external oblique, the internal oblique, and the erector spinae, come on in a sequence of ways to optimally produce force.
If we go back to the systematic review in 2014, the Akbari study in 2008 had the motor control group only perform isometric draw-in maneuvers for 10 reps of 10-second holds, and then were instructed to do the same exercises as the general exercise group. Unsurprisingly, there was no significant difference between the groups, as there is no evidence that a static draw-in maneuver on its own is an effective way to reduce low back pain.
And so, is abdominal wall training the most important intervention for everyone with low back pain? Not always. As I alluded to, there are often many other tensed compensatory muscles that are placing excess strain on the low back, and strengthening your core isn't always going to be the answer. The key takeaway, however, is that individual assessment is always going to be necessary. So as much as I stress the importance of the transversus abdominis, nobody really needs to do a static draw-in maneuver to minimize their low back pain or improve their motor control. This simply isn't enough training. What is more important is how well can your transversus stay shortened in preparation for the obliques to do their job during higher load tasks. To produce force optimally, we can't go straight into strength training exercises such as heavy curl-ups, heavy sit-ups, bird dogs, whatever it be, unless we have that adequate motor control strategy. If we don't have that strategy, we can't produce that force optimally, and sometimes we can actually experience pain from that. And so you might be asking yourself, how do I properly assess the abdominal wall if I don't have a real-time ultrasound scanner? Click this video up here to watch part 2, where I'll take you through a hands-on assessment of how to properly assess and treat the abdominal wall. Thanks for watching.